Stroke alert in the emergency department. Most of our time with our patients is limited, so it is important that when someone presents to the ED with stroke-like symptoms, that we use our time wisely. The brain is an important organ, so we must work fast and efficiently to deliver the best patient care. Here are the learning objectives and goals for this lesson. After completing this presentation, the staff nurse will be able to recall the department time goals for proper stroke treatment, identify signs and symptoms of a stroke in order to perform a rapid initial assessment, perform a full NIH assessment using the right tools in order to determine the severity of symptoms, and calculate 2 practice TPA doses correctly in order to administer TPA. The goals are as followed. The staff nurse will be able to differentiate potential stroke patients. The staff nurse will activate stroke protocols to treat the patient in a timely manner. And the staff nurse will be competent in administering TPA. What is a stroke? It occurs when there is a disruption in blood flow to the brain. It is important to understand the differences in order to treat it appropriately. There are 3 types of stroke: ischemic, hemorrhagic, and TIA. 87% of strokes are ischemic. These strokes occur because something is blocking the blood flow to the brain. Some potential causes could be narrowing of the arteries, plaque, or blood clots. The next type of stroke is hemorrhagic. It can either be an intracerebral or a subarachnoid hemorrhage. The intracerebral is the most common and is caused by a ruptured artery, which will then fill the brain with blood. Lastly, we have TIA, the transient ischemic attack. These are caused by some sort of temporary blockage of blood flow. They don't last more than 5 minutes and symptoms usually resolve. The importance of these is that they could be a potential warning sign for a future stroke. Using the ACLS stroke algorithm, we have certain time frames that we use to meet them for each stroke. As a department, these are the goals and help us deliver the best patient care. Door to MD eval is 10 minutes. Door to CT scan, 25 minutes. Door to CT results, 45 minutes. Door to needle, 60 minutes or 3 hours from the onset of symptoms. And door to admission, 3 hours. A triage nurse has the most important role when it comes to a stroke. It is our job to be competent with the signs and symptoms of a stroke. Once we have identified a potential stroke patient, it is our job to notify the physician and start stroke protocols and time goals. Another key ingredient is the onset of symptoms. This can be helpful whenever we are determining if a patient is eligible for acute treatment. Some of the symptoms include unilateral numbness or weakness, slurred speech, any vision changes, dizziness, headache, loss of balance. Once our patient has had their CT scan, it is a primary nurse's responsibility to obtain an NIH scale. Using the chart on the right-hand side, you will score the patient in each category, giving them a total score. The NIH score helps to determine the severity of stroke based on the symptoms that was caused by the stroke. A score of 0 means that there was no stroke symptoms. 1 to 4 equals a minor stroke. 5 to 15, a moderate stroke. 16 to 20, moderate to severe. And 21 to 42 is a severe stroke. Figure 5 on the left-hand side is a tool to help determine best language and dysarthria that is on your NIH scale. Tissue plasminogen activator, also known as TPA. This is our clot buster and is used for ischemic strokes. There are many contraindications to consider prior to administering TPA. Some of them include any previous stroke symptoms, any major surgeries or traumas in the past 14 days, post-MI in the past 3 months. Also, the patient's already receiving any anticoagulants and they have high lab values, INRs, PTTs, then this would be contraindicated as well. TPA requires 2 nurses to calculate the dosage prior to administering the medication. In order to get the total TPA dose, you need to multiply the patient's weight in kilograms by 0.9. The vial of TPA contains 100 milligrams and is a 1-to-1 ratio, so it's 100 milliliters. The amount not needed needs to be wasted from the vial before drawing a bolus and infusing the medication. So take 100 minus the total TPA dose to know how much to waste from the vial. Next, you will need to give 10% of that total dose as a bolus. So take your total TPA dose times it by 0.1. Remember, this is a 1-to-1 ratio. So if you get 5 milligrams, then you'll be giving 5 ml bolus. Lastly, you'll need to find your infusion dose and rate. So take your total TPA dose minus your bolus. That'll give you your infusion dose and rate. And since it is a 1-to-1 ratio, your rate will be milliliters per hour. Your infusion will go over 1 hour. Attached is a YouTube video on how to mix, calculate, and administer TPA. It is important for the primary nurse administering TPA to stay in the room with the patient and monitor for any additional bleeding and vital signs. You will be doing an NIH scale every 15 minutes during the infusion to note any improvements or decrease in neurological function. TPA is a blood thinner, so it's important to watch for any major or minor bleeding that can occur. Major bleeding being any hemorrhagic strokes, and minor bleeding at the IV sites, gums, and urine. Make sure that you do not do any sticks after you've started the infusion. Vital signs should be recorded every 15 minutes during the infusion, then 30 minutes for the next 6 hours. Our patient should hopefully be out of the department by then, so it's important to give a bedside handoff to the ICU nurse so he or she knows where to pick up with the vital signs in the NIH scale. Here are a couple TPA practice calculations. The first one is we have a patient who weighs 68 kilograms. To get the total TPA dose, we're going to take their weight, times it by 0.9, giving us 61 milligrams. We'll need to next waste the amount we don't need out of the vial. So we have 100 minus 61 equals 39 mLs. Out of the 61 milligrams, we need to give a 10% bolus. So that'll be 61 times 0.1, giving us 6 milligrams. Next is our infusion dose. So you're going to take the 61 milligrams and minus the 6 milligrams, giving us 55, which will also mean that our infusion rate is going to be 55 milliliters per hour. And remember, this is given over an hour. Next, we have a patient who weighs 95 kilograms. The total TPA dose will be 95 times 0.9, giving us 85.5. We'll round up to 86 milligrams. We're going to waste 14 mLs. We're going to take 10% of our 86 milligrams, giving us 8.6. And then for our infusion dose, we're going to do 86 milligrams minus the 8.6 milligrams, gives us 77.4, which means our infusion rate is going to be 77.4 milliliters per hour. Dealing with a stroke patient can be scary, so protocols and goals are set in place to make this process easier and efficient. Time is brain, and it is our job to save it.